Hi, hello. My name is Ernesto Perez Colome. I'm a second year internal medicine resident at HCA Florida Kendall Hospital. And today I would like to talk about a case that we call a dairy kiss, a case of a mitral kissing vegetation secondary to abiotrophia defectiva endocarditis. As we know, infective endocarditis is the infection of the heart endocardial surface, usually involving one or more cardiac valves. Because of the proximity of the structure in the heart, the infection might be spread within it, and lesions of the mitral valve that are secondary to the aortic infective process are rare, and they are known as mitral kissing vegetation because of the aspect of the aortic valve giving a kiss throughout the vegetation to the mitral valve. The majority of the cases of infective endocarditis are thought to be caused by Streptococcus or Staphylococcus species. However, there are several microorganisms that can cause infective endocarditis. An uncommon cause would be abiotrophia defectiva, causing less than 5% of the infective endocarditis. And this is a part of the normal flora of the oral and gastrointestinal. However, it can become pathogenic once it enters the bloodstream, causing endocarditis. This endocarditis is known to cause more whole valve disruptions, resulting in heart failure and higher embolization rates when compared to other causes of endocarditis. So our case represents an unusual endocarditis just by the simple reason that it was caused by abiotrophia defectiva, and also because it was presenting as a mitral kissing vegetation. The entity that is only recognized in less than 10% of the endocarditis. Our patient was a 22 years old male with history of bicuspid aortic valve and aortic coarctation repair at 20 months old, who presented to the emergency department due to symptoms of fever, chills, and weight loss for around a month. On the initial physical examination, patient met sepsis criteria by having fever and tachycardia. Also, a 3 out of 6 diastolic murmur was heard. Initial labs revealed anemia and elevated C-reactive protein with no additional abnormalities. Viral testing were all negative on initial workup. Given the symptoms of fever and the findings of the murmur, a transthoracic echo was performed that revealed highly mobile structure resembling a vegetation and severe aortic regurgitation, which was later confirmed through a transesophageal echo that revealed that the vegetation was linked to the left cause of the aortic valve, extending to the anterior left leg of the mitral valve, consistent with a mitral kissing vegetation. The initial cultures taken on arrival, they grew abiotrophia defectiva in 2 out of 2 sets, and IV antibiotics with ampicillin and gentamicin were started, causing negativization of the cultures. Later, the patient was discharged with a PICC line to continue antibiotics for at least 6 weeks and instruction to follow up with cardiothoracic surgery for a possible aortic valve replacement. With the previous case, we would like to emphasize that even though abiotrophia defectiva endocarditis and a mitral kissing lesion or vegetation are not the most common presentation, they represent an increased risk for morbidity and mortality even in younger patients, and how early diagnosis and treatment can prevent the patient to have severe valvular dysfunction and increased risk for cardiovascular decompensation.